Dr. Sarva, I think we can go ahead and start. Can you hear me?
Yes. So should I just begin?
No, I'm going to give an introduction.
Okay.
Hi, everyone. Thank you so much for joining us this morning. It's a pleasure to welcome you all to the first grand rounds of the academic year 2022 to 23. And we have a very special guest today, who is our own graduate, Dr. Harini Sarva. She did her medical school and residency at SUNY Downstate, and she was also a chief resident here, following which she completed a 2-year fellowship in movement disorders under Dr. Susan Bressman at Mount Sinai. She currently now works at the Movement Disorders Institute at Weill Cornell Medicine, where she is the current director of the Parkinson's Disease and Movement Disorders Institute. So it's my pleasure to welcome her. And Dr. Sarva, thank you for joining us. And I hand over the mic to you. We can proceed. Thank you.
Thank you, Srinath, for the wonderful introduction. And thank you, everyone, for inviting me. I wish I could be there in person. Been nice to be back at home at Downstate. So I'm going to go through approach to the shaky or tremulous patient this morning. These are some of my financial disclosures with regards to clinical trial support and consultancy work. I'm going to start by defining what tremor is and go through some of the most common tremor disorders like essential tremor, Parkinson's, and dystonia. So tremor is a rhythmic involuntary movement of one or several body regions, typically occurring around a joint or muscle that is free to oscillate. While distribution and symmetry are important features to note, tremor is defined by the state of the tremor, meaning is it occurring at rest when there's no voluntary action? Is it occurring with voluntarily maintaining a position, as in postural tremor, or when performing a voluntary movement? And that can be intentional or an action tremor that occurs throughout the entire movement. So generally speaking, when we think of someone with tremor, we broadly divide it into rest tremor and action tremor. And action tremor incorporates both postural and kinetic tremor. When we look at rest tremor, the most important diagnosis is Parkinsonism, most commonly being Parkinson's disease, but also dystonia. And sometimes there's an isolated rest tremor and no other features. And for those patients, we just watch and monitor and see if something else comes up. Dr. Valsamis used to always say that whatever it is will declare itself eventually. And that's usually what happens, that these people with an isolated rest tremor, after a year or two, you'll see more of the rigidity and bradykinesia, and you're able to diagnose them with Parkinson's. With regards to postural tremor, it can be position dependent or independent. And that usually relates to whether there's presence of dystonia or not. So if there's certain positions where the postural tremor comes out more, it's more likely to be a dystonic postural tremor, as opposed to, say, an enhanced physiologic tremor or postural tremor that you see with the central tremor. And of course, with kinetic tremor, which is your standard action tremor, it can occur upon intention with specific tasks like writing, and that's called a writing tremor, or with a central tremor. There are important historical clues that will sort of guide you with regards to what type of tremor diagnosis it is. Age of onset is important because that can either lead you to consider dystonia or even ET. We've had some patients with essential tremor who developed tremor under the age of 5 years. Body regions that are involved are important. So ET typically is beginning in the arms. If you have an isolated head tremor and nothing else, you should think of cervical dystonia. Are there any positions or maneuvers that elicit or suppress the tremor? If there's certain tasks, for example, like writing or playing an instrument, it's probably a dystonic tremor. The time course and evolution, most of these primary tremor disorders are slowly progressive over time. Parkinson's, essential tremor, dystonia. If it's happening after a sudden incident, you may want to look for a structural lesion. What are other associated symptoms or sensations or exam findings? Is there bradykinesia? Is there pulling? Is there neck pain with the head tremor? Those can all guide you in terms of what the overall syndrome is. what medications the person is taking, because there are many medications that can either aggravate or cause tremor. Medical history is important. Family history, to a certain extent, is becoming more and more important as we do more genetic testing for dystonia, Parkinson's, and also essential tremor, but the tremor syndromes in families don't always run the same way. And the most important question to really ask, and this really relates to treatment management, is how much is the patient aware of the tremor, and how much does the tremor really impair functionality? If it doesn't, it's just a wait and see game. When we're examining the patient, it's important to have them seated comfortably, shoes off, sleeves rolled up, so we can look for any resting limb tremor. I often do some distraction maneuvers like counting backwards to see if any head tremor pops up, because most patients, when they focus enough, they can control their resting tremor or head tremor. When we're looking at postural tremor, we ask them to extend their arms and put their arms in the wind beating position like this. And we want to see if the tremor is regular or irregular. If it's regularly oscillating around a joint, it's most likely to be an essential tremor as opposed to something that's irregular, which may be dystonic or having an overlying myoclonic feature to it. It's important to know what joints are involved. If it's just only the arms, it's most likely to be an essential tremor because it is the most common tremor disorder. But if you're starting to see neck and arm involvement, it could be a segmental dystonia. Is there a direction to the oscillation, meaning that is it completely regular, or are there certain points where it changes direction and it has sort of features, then you worry that it might be more of a dystonic tremor. Is it reemergent? Now, reemergent tremor, and I'll show you a couple of videos, can suggest possibility of an underlying dopamine deficiency syndrome as opposed to being ET. And of course, you want to look for posturing and distractibility or suggestibility. When we're evaluating for a kinetic tremor, there's several maneuvers you can do. Finger to nose is the most common. Having them draw spirals can actually be important because if the spirals, to a large extent, can clue you in on what the diagnosis is. Doing other writing samples, having them pour water from one glass to another, all of those things can elicit the tremor in ways that can help you with the diagnosis. And you want to see if it's mostly an intentional tremor or if it's really throughout the action. So just to review spiral drawings, this is a normal spiral diagram. This is a classic Parkinson's spiral. You see it collapsing on itself. These four up here are your classic ET spirals. And the lines I drew because they demonstrate an axis around which the ET tremor changes. So it starts off like this, they start shaking, and then it continues in this direction, and then after which it sort of shifts a little bit and then continues along. So there's that classic directionality to it. With dystonic tremor, there's really no directionality at all. There's no pattern to it. There's no axis around which it shifts at all. And that relates to this irregularity in the dystonia. So after the history and the exam, there are a wide array of potential causes for tremor, a number of neurodegenerative diseases, Parkinson's, spinocerebellar ataxias, Wilson's, fragile X-associated tremor ataxia syndrome, a lot of genetic isolated dystonias like DYT1, mitochondrial disorders, a whole host of infectious and inflammatory etiologies. There's also neuropathic causes that can lead to a tremor as well. And of course, other structural lesions like strokes and neoplasms. So to go over a few main tremors, starting with essential tremor. So in 2018, the International Parkinson's and Movement Disorder Society changed the definition of ET. And they're looking at it similar to the way that they look at dystonia by basing it on a two-axis diagnostic scheme. Axis 1 looks at the clinical presentation, and axis 2 on etiology. And what they've defined in terms of ET for the clinical presentation is onset of tremor in the upper limbs that occurs for at least 3 years. And they did that as sort of a time point because after 3 years of bilateral arm tremor, you can more or less safely say that this is mostly essential tremor. If you see patients with less than 3 years with arm tremor, you really want to watch out for bradykinesia and rigidity because Parkinson's patients can present with this intention tremor even before like a resting tremor. They've also excluded isolated head or voice tremors, which can be dystonic. And what they've said is that if you find an etiology, like a genetic mutation, then the diagnosis of the tremor is based off of this discovered etiology. 90% of the time, ET involves the hands, less so in the head or voice. When you actually watch chronic ET patients walk, you will notice slight widening of their stance, difficulty with tandem gait, and it's likely related to the underlying pathophysiology where the cerebellum has been affected. And of course, like all other movement disorders, there are a number of non-motor features. And I think a lot of this has to do with the large network-based pathology that we're seeing in these movement disorders involving the corticothalamic cerebellar tracts. So this is one of my patients with a longstanding ET, I believe either for 20 or 30 years. So you're seeing a little bit of flexion movement in the wrist at rest, and that's not uncommon in patients who've had essential tremor for 20 plus years. And right away, you see the postural component. There's no delay. Asymmetry is allowed, so the right is clearly more affected. And it's also very common in essential tremor to see the postural tremor be more prominent in the wing beating position. Now I'm doing the finger chin maneuver because his ET is so bad, I didn't want him to poke himself in the eye. But you can see that there's the action tremor throughout the entire movement and not just in the intentional phase. Now I'm also checking for bradykinesia. You know, he is over 65. So in those patients who've had a long-standing history of ET, we do see, you know, in about 4% of patients developing some sort of Parkinson's and having this ET-PD phenotype. It doesn't mean that essential tremor necessarily increases the risk for Parkinson's unless they're starting to develop other symptoms like REM sleep behavior disorder, anosmia, constipation. All of those together will likely contribute to the development of PD. Now, his movements are not exactly perfect, and there's a lot of tremor interference, but he didn't have any rigidity on exam. And it's important also to check for foot dexterity as well. And the heel and tap the toes, the right foot. Other maneuvers I do especially when there's so much tremor, I have them demonstrate trying to play the piano with either hand. And if those movements are fairly good, then it's less likely that there's a Parkinsonian component. It's probably just tremor interference. Another maneuver that I like to do in the office is have them bring water to their mouth with a plastic spoon, because sometimes the finger to nose maneuver doesn't really show a significant tremor, and this at least gives us an idea in terms of what their level of functionality is. And you can see that he's very, very cautious in bringing water to his mouth because he doesn't want to spill it. This was a paper published by Ilan Lewis about 8 years ago, and it still holds true. When you're evaluating the ET patient, the amplitude of the kinetic tremor is generally bigger than that of the postural tremor. And postural tremor alone is rare in ET. The postural tremor is not featureless. It's really a wrist flexion extension movement, not a rotatory movement. If you're seeing a rotatory component, think more Parkinson's. It's regularly recurrent and directionally symmetrical. And that also relates to those spiral diagrams where, you know, even though they change directionality, the spiral itself is more or less symmetrical. Arm tremor can be asymmetric. Postural tremors are typically out of phase. So when you're taking the history, patients will normally say that they hold a soup bowl or a coffee mug with both hands. That's what they mean by out of phase. So there's destructive interference of the tremor waveforms, and then they're able to bring the cups to their mouth. Tremor aligns along a single axis, and that's because of the directionality on spiral diagrams. Intention tremor is seen in 50% of patients in the hands and in the head. Rest tremor, like we saw in the first video, can occur in the arms as a late feature in up to 20% of cases. If you're seeing rest tremor on the legs, you really should consider an alternative diagnosis. Arm tremor typically precedes head tremor. Head tremor generally resolves when lying down. Cervical dystonic patients can still appreciate a head tremor and discomfort when they're lying down. And some will actually say that they can't even get a comfortable position. ET patients are often unaware of mild head tremor. And it is a progressive condition, and tremor continues to worsen over time. And that it's not a linear worsening. We see patients who've been diagnosed in their teens or 20s, and they come in their 40s or 50s, because that's really after that much time where it starts to impact their daily quality of life. So family matters, but individuals may not all progress the same way. And the biggest risk factors for faster progression is the age of onset of tremor. So if they're developing it in over 60 or 65, they tend to progress faster. When the tremor starts, if it's already severe and impacting functionality, it's going to get worse right away. And if they've had it for a long time already, it's going to progress right away. If they're like 70 years old and it's a very mild tremor that they had in both hands for at least 3 years, and it's not really impacting them, that person will probably have a slower progression than if the same 70-year-old came in with 3 years of bilateral arm tremor where they're having trouble eating or holding a coffee cup. So generally, when we see these patients, if it's a new onset tremor, and if they say it sort of started out of the blue, or it's good to make sure that there's not an underlying etiology. So in addition to checking for their medical history and medication history, checking for TFTs, B12 deficiency, doing a brain MRI. And then ultimately, treatment depends on how disabling it is. If it's occasionally disabling, then you could do PRN, beta blocker. I don't recommend alcohol. Actually, I know a lot of patients who've seen older physicians have said, it's okay to take a glass of wine. I actually don't tell patients that. And I actually don't even give alprazolam anymore. I think because of the high addiction potential, I don't even bother using it. If it's not bothersome, we just watch them on a yearly basis. A lot of patients don't even want to take meds, and then I'll just recommend occupational therapy for hand strengthening, wrist weights. There's actually a device on the market for as an external peripheral stimulator, but it's too cost prohibitive. And if it is really bothering them, then we'll try propranolol, primidone, some sort of combination, maybe topiramate. If they fail, then we'll definitely talk to them about surgical options, whether that's deep brain stimulation or the focused ultrasound. So the two most important differentials are dystonic tremor and Parkinson's tremor in these patients. Dystonic tremor, unlike ET, is very irregular, and I'll show you some examples. It definitely has more of a directional component, meaning that there are certain postures that you can put the arm, for example, where the tremor will come out, unlike in ET, where regardless of which position the arm is in, the tremor will be there. There's no definable axis on the spiral drawing. You saw that very shaky spiral earlier. The head tremor doesn't resolve with lying down, and you'll notice clear posturing being present. In terms of Parkinson's tremor, it is greater in the distal hand joints. There's a rotatory component. If you see a unilateral postural tremor or a resting leg tremor, you should really be suspicious for Parkinson's. And of course, the important clue is bradykinesia and rigidity. So Parkinson's tremor is a classic characteristically 4 to 7 hertz resting tremor. 70% of the time we do see that, but oftentimes we'll see a little bit of postural or action tremor and not much of a resting tremor. In fact, there are some patients who have more of a disabling postural tremor than even a resting tremor. Recently, I diagnosed a 70-year-old lady who came in with like just 2 or 3 years of a really bad unilateral postural tremor. And look, I was sort of concerned about dystonia versus PD in her. And then I re-examined her and thought some of her movements were more bradykinetic, and she had a positive DAT scan, which showed reduced dopamine uptake on the right striatum. This response to alcohol, I mean, this holds true for all tremors, so it's not really characteristic of PD tremor or ET tremor. So even though it's, historically asked as a question, it really doesn't have a lot of meaning. the most important distinction in terms of postural tremor between ET and PD is that in Parkinson's, the postural tremor typically emerges after a variable latency, whereas ET postural tremor, in that first video that I showed you, it occurs immediately after lifting the arms. And the frequency of the postural tremor is similar to the classic resting tremor. So I'm going to play this very old video by Dr. Jankovic.
Sometimes you get no response from Cinemat. Is that correct?
And you see this very classic resting tremor in the right arm. You actually see a pill rolling component distally involving the finger joints, and it has a very rotatory component to it.
Okay.
The patient has classic signs of Parkinson's disease in his off state, including a coarse pill rolling tremor, stooped posture, hypophonia, poverty of associated movements, and masked pain. He has difficulty.
It's not uncommon to see this tremor reemerging when patients stand and walk, and that is also considered a resting tremor because the arm is in a resting state here.
So your wife is now going to give you 0.5 milligrams of apomorphine. Could you stand up for me?
So tremor is gone after apomorphine.
Subcutaneous injection.
He's walking better. You don't even see the tremor when he's walking either.
Sometimes.
So this is one of our research subjects who came in the off state. And I'm going to just fast forward a little bit. You can already start to see this mild tremor in the left arm. This is sort of a new resting state for him, even though he's holding this piece of paper. Now he's fully relaxed. Again, you see this rotatory component in the left arm. Historically, patients will say that they, if they say that they see the tremor when they're just sitting there, that's a big red flag, but sometimes they'll just say, I'm holding my newspaper and one of my hands starts to shake. And so that should, concern you a little bit that it might be underlying Parkinson's. There's a little bit of a delay, and then there's also this unilateral postural tremor in the left arm, about the same frequency as when it was at rest. So that's that kind of very subtle re-emergent tremor after a few second delay. He has a little bit of an intention component. That's very common as well. You can see moderate to pretty severe bradykinesia in his hands. So again, Parkinson's and Parkinsonisms are defined by the presence of bradykinesia, which is the most important feature. Resting tremor can occur in about 70% of patients, but tremor alone is not diagnostic of Parkinson's, especially as I showed you two classic examples, but then there's some patients who will just have a unilateral postural tremor or a little bit of an intention tremor in both hands for like a year, and you don't really think of Parkinson's just based off of that history until you see the bradykinesia on exam. So like ET, PD also has a number of non-motor symptoms: mood disorders, autonomic dysfunction, sleep dysfunction, cognitive dysfunction. It's important when you're asking about non-motor symptoms in these patients to ask about REM sleep behavior disorder, constipation, inattention, word finding difficulties, and mood disorders. So those are all important historical clues. When added together, including anosmia, that it might be more of a dopaminergic deficient syndrome as opposed to ET. In terms of generally managing these patients, it all depends again on functionality. If the tremor isn't bothersome, we'll just watch it or provide occupational therapy. If it is, occasionally you can give them PRN beta blockers, but really if it's quite disabling, I often prescribe carbidopa, levodopa, and after a gram, if it's not working, surgical intervention is warranted. Dystonic tremor. So dystonia is a movement disorder characterized by sustained or intermittent muscle contractions causing abnormal, often repetitive movements, postures, or both. Dystonic movements are typically patterned, twisting, and maybe tremulous. And dystonia is often initiated or worsened by voluntary action and associated with overflow muscle activation. And this has been the operational definition for nearly 10 years. Again, dystonia, like ET, is classified using a two-axis scheme. So axis one, looking at the various clinical features, age at onset, body distribution, temporal pattern, and axis two, looking at etiology. I like this slide because this is how challenging it can be to diagnose someone with dystonia, because the movements are not too fast, not too slow, not too big, not too small, and not really that regular. But the two important features for dystonia are task specificity, meaning that there are specific tasks that will bring on a dystonic movement, like writing or playing an instrument, and a sensory trick, which is any maneuver that a patient can utilize to ameliorate their symptoms. Dystonic tremor can be postural, kinetic, even resting in areas where the dystonia is subtle. It can be very jerky in quality, and I'll show you some videos. It's usually worsened when you're performing an action that moves the body part against the pole of the dystonia. And it's relieved when the body part is positioned in accordance with the pole, and that's called the null point. So this was one of my patients who developed bilateral arm tremor in her 20s. So it's been about 30 years since her symptoms started by the time I saw her. And you can, it's not just the arms that are affected. But there is neck posturing, so she's a little bit tilted to the right, turned to the left. And she has that classic spasmodic dysphonia, where she has like this strangulated voice with overlying tremor.
Turn your head all the way to the left. Look with me. Turn your head all the way to the right. Look at me. Put your head all the way back. Good. And look at me. Touch your chin to your chest. Good. Look up at me. Now put your hands in your lap like this, both of them, and count back from 20. 1, 2, 3, 4.
A little bit of a subtle tremor here in the left hand at rest.
11, 12, 13, 14, 15, 16, 17, 18, 19, 20. Now bring your arms out in front of you, both of them.
So you see the posturing at the wrist and the fingers. There's this pulling outward of the left wrist. There's more of an irregular quality. This position brings out the tremor more because this is against the pull of what the dystonic muscles want to do. And this reduces the tremor because this is what the dystonic muscles want to do. So you see some hyperextension at the elbow. So there's posturing upon doing the finger to nose movement bilaterally. She's not really ataxic. It's mostly that the tremor is prominent upon the target. This isn't classic bradykinesia that you see with Parkinson's, but with dystonia, the movements can appear very slow and deliberate, and that's because of interference of the co-contraction of the agonistic and antagonistic muscles. Almost like this kind of very weird writhing quality to dystonia.
Turn. Faster. Turn the other hand.
but they're not getting smaller and they're not really breaking down like you would see in a classic Parkinson's
right
patient.
foot stomp like this.
So this is also a patient with dystonia, and you can see this prominent jerky right hand resting tremor. There's posturing of his fingers.
He raises his arms and maintains the same posture.
Frequency is very high. It's a little jerky in the left. This maneuver is bringing out the right arm postural tremor more.
During finger to nose testing.
And there is posturing at the elbow joint when he's doing finger to nose. This is one of my patients.
Yes.
He actually developed difficulty writing as a school-aged boy. And he had to really switch hands.
Arms like this.
And he's been quite debilitated for a long time. I think he was already around 50 years by the time I saw him. And you could see this really jerky, prominent left arm tremor with this pulling sensation that you see particularly at the wrist. A little bit less when he does this maneuver. So there is a slight null point.
So put your arms out again. Your hand is turning like this too. Touch your chin. And the other hand.
Just very jerky quality to it toward the end of the target. And he can barely write. I mean, he has significant posturing at the shoulder and elbow. You can see how he's trying to stabilize himself with his other hand, but that's just leading to more tremor. He can barely complete a sentence. And his left arm, there's significant posturing at the elbow, tightness of the grip. And this is him after deep brain stimulation, shortly after. And the frequency of the tremor is a little bit less. It's still there in the left arm, but the right arm tremor has significantly improved compared to the prior video. And he has better control in the finger to nose movement than he did prior to DBS.
Now with your right hand. It's very hard, okay.
And he only had unilateral left palatal DBS at that point.
Okay.
And writing is also a little bit easier after the palatal stimulation.
Yeah. Yes.
So sensory tricks for these patients are any maneuvers that alleviate the dystonia. And you notice this a lot more with patients who have isolated head tremor. They'll either hold their chin up, they'll lean their head against the wall. Some of them might even wrap their neck with a scarf. It doesn't have to be antagonistic to the dystonia. It can be variable in nature, and the duration of the effect can also be variable. And each trick is specific to that particular patient. And there are many different types of tricks: tactile, visual cues, auditory, and even thermal. Task specificity is really another important quality to their tremors. That can occur only in writing. So there are some patients, when they start writing only, that's when their tremor begins, and that's most likely a dystonic component to their tremor. Again, non-motor features are important to ask in these patients when you're taking a history, especially someone who comes in with an isolated head tremor. You want to ask about neck pain. Are there any maneuvers that will alleviate the head tremor? If they have any jaw tremor, is there any jaw clenching? And if there's any voice tremor also, are there specific sounds that they can make or not make? Treatment approach, again, symptomatic. If it's focal or segmental dystonia, botulinum toxin. If there's a large tremor component, you can use propranolol or primidone. If there's a genetic dystonia like dopa-responsive dystonia, carbidopa-levodopa is commonly used. If it's affecting many body regions, you can try benzodiazepines, trihexyphenidyl or baclofen, and if it's refractory to everything, deep brain stimulation. So briefly about enhanced physiologic tremor, it is an increase in amplitude and frequency of baseline postural or kinetic tremor. There really isn't that intentional component as we see with ET. It's transient and should be reversible. The frequency is much faster and the amplitude is much lower than what we generally see in essential tremor. There are many causes, including several medications, antiepileptics, neuroleptics, a lot of different toxins, metabolic disturbances. A lot of coffee can also aggravate the tremor, and really the treatment is treating the underlying cause. If you can't treat the underlying cause, you can try small doses of propranolol. So drug-induced tremor, typically we associate this with antipsychotic use. It can be a resting tremor, it can be an action tremor, it can be a dystonic tremor. The onset is typically after, though may not have to be immediately after taking a specific medication like haloperidol or aripiprazole. It may be gradual in onset and gradually worsen over time. The dose-response relationship is present, so hopefully as you lower the doses of the offending agent, the tremor should improve. And if they've been on stable doses of medication, then typically the tremor should not progress. If there's someone on an antipsychotic agent and they're saying that their symptoms are getting worse, but their medication hasn't been increased in a very, very long time, and you might want to consider that there might be a primary tremor disorder like essential tremor or even Parkinson's in those patients. If you discontinue the agent, theoretically, it should lead to the resolution of the tremor. It may not happen right away. So for antipsychotics in particular, there may be a latency of 6 months or even longer. If you really can't lower or change or stop the medications, you can always use beta blockers or Parkinson's medications. Holmes tremor. It's typically a fairly slow tremor at 3 to 4 hertz. It occurs in all phases, rest, posture, and with action. Can be irregular like a dystonic tremor, usually due to midbrain and thalamic lesions, although you can also get it from cerebellar lesions. There's often a latency of 2 months between the lesion and tremor development. Treatment-wise, you can try carbidopa-levodopa, or if it doesn't work, then deep brain stimulation. So this is a video of someone with a left Holmes tremor after a stroke.
This man with Benedict syndrome shows complete ptosis. It's slow rest, postural, kinetic tremor of his left hand.
So all 3 phases, that's really what the key distinguishing feature of the Holmes tremor. It is unilateral at rest, contralateral to the lesion. And briefly about cerebellar tremor, typically associated with spinocerebellar ataxias or other cerebellar pathologies. It's a kinetic tremor with a worsening intentional component. It's a slower tremor than ET. And there are obvious cerebellar signs on exam and other signs of cerebellar dysfunction other than just pass pointing. And thalamic DBS can improve their tremor.
This patient exhibits a kinetic or action tremor, both upper extremities during finger, chin, finger testing. The larger amplitude limb oscillations as he approaches the target of the examiner's finger.
So he's clearly not hitting the target here, as opposed to the dystonia patients who had a pretty big intention component. They were not ataxic. He's just not able to hit the target at all because of his cerebellar pathology. His gait is wide-based, it's unsteady. So
his gait is on a broad base, requiring use of cane.
So this is most likely due to a prominent cerebellar pathology as opposed to being something that occurs with longstanding essential tremor, for example. So in summary, when you're looking at someone with tremor, if there are features of the exam that are distractible or variable, it may not be a organic tremor disorder, it may be a functional tremor disorder. So if they start off and the tremor pattern and frequencies change over time in the middle of the exam, or if they're able to do certain things that you think they wouldn't be able to do with the level of their tremor, it may not be entirely an organic tremor. If there's no distractibility or variability, then the question is it task specific or not? If it's task specific, then there may be a dystonic component to it. If not, and it affects both arms for more than 3 years, it might be more likely to be an essential tremor. If it's not an action tremor, but predominantly a resting tremor, then you want to consider Parkinsonian syndrome. If it's a predominantly unilateral postural tremor, you might also want to consider Parkinsonian syndrome or dystonia. And if you see isolated vocal tremor or isolated head tremor, it can include dystonia as a differential diagnosis. If you're seeing mixed tremors, so you see a little bit of dystonic tremor in the neck, ET-like tremor in the arms, maybe a resting tremor in the leg, it could be due to a drug-induced tremor, like antipsychotics can give you a mixed tremor disorder. Neurodegenerative diseases like Wilson's can give you these mixed tremor disorders. Spinocerebellar ataxias can. So it's a wide gamut of pathologies that can give you this kind of tremors. But if it's more of a mixed tremor disorder, it's either due to medications or probably due to other neurodegenerative diseases that are affecting multiple different pathways. So in summary, there are many different types of tremors. Tremor disorders can often overlap, and looking at really more of a syndromic approach is the key. Often close follow-up for evolution of symptoms is needed to be able to accurately diagnose a patient. So don't oftentimes jump the gun. I say I really just don't know what this is often to patients, especially when they come very early or there's not anything else really on exam. And treatment really depends on how much the tremor is bothering them, and the response can be variable. Thank you, and I look forward to any questions.
Thank you for this wonderful lecture, Dr. Sarva. You can now open the floor for questions.
Yes, Dr. Brian and Ziska. We recently diagnosed a patient with orthostatic tremor, which I'd never seen before. I'd seen films of it, but I'd never actually seen it live. This was a woman who came in with headaches and suddenly developed a tremor of the left leg, a slow tremor of the left leg. I looked up the not very much literature on it, and apparently there are fast tremors and slow tremors. Most of them are fast. There's no other tremor, and it's often a very high frequency. I'm beginning to think that this may well have been a functional disorder because she had her gait got worse without even in the other leg. So can we just talk about orthostatic tremors for a minute? Is there any treatment? Is
Sure.
there any way of diagnosing it?
Sure.
Yeah.
Sure. Thank you, Dr. Francisco. It's good to see you. So typically orthostatic tremors affect both legs. There's a latency when they stand up. After a few seconds, you'll see this large volume, large amplitude tremor. It's usually about 13 to 17 hertz. So when they do surface EMG, you'll really pick up this very, very fast electrode. And that's probably the biggest diagnostic clue. You can actually hear this kind of helicopter humming if you put your stethoscope to their calves or their thighs as well, but sometimes you can't. It usually goes away when they're walking, but they really can't stand still, or if they're leaning their legs. One of the tests that we used to do is we'll have them lie on their back and then push their feet up against the wall, sort of mimicking a standing position to see if the tremor comes out or not. They'll often say that when they lean up against something that the tremor goes away. Treatment-wise is tricky. We've tried gabapentin, we've tried propranolol, we've tried clonazepam. It can really be a very, very tricky tremor to treat.
Do we know its basis, its pathophysiology at all or not?
Not entirely. It's probably related to cerebellar dysfunction. We actually diagnosed a patient with orthostatic tremor and someone who had a spinocerebellar ataxia. When you can also see it in Parkinson's disease as well. So there are a lot of different underlying pathologies. It can be either cerebellar or even dopaminergic.
The other thing I want to talk about is the Holmes tremor and rubal tremors. Are they the same thing or not? Yes. Holmes described a tremor in all positions, resting, intention, I think, postural. And supposedly it was associated with a red nucleus lesion, although more recent literature seems to say that it can occur even without red nucleus lesion, and it's really a cerebellar outflow tremor.
Yes. That's correct, yes. So you're right. And so it's not just midbrain red nucleus lesions, but the thalamic outflow tract lesions can lead to this rubal tremor.
Okay, thank you.
Sure. One thing that we are sort of seeing when we're for patients with tremor, in particular, whether it's Parkinson's tremor or essential tremor, when we're doing the focused ultrasound, for example, and we've done a number of these cases, that one of the probably the most annoying things that people describe is ataxia afterwards. It's transient, so it can be gait unsteadiness. We recently had a patient who had very large ataxic movements that's been quite bothersome. We don't entirely know how long it's going to take for those patients to recover. There's about 4 years worth of published data on using the ultrasound for tremor, and it's pretty much suggests that it'll take at least a year or two for some of these symptoms to go away. So while it's definitely provided a tremendous opportunity for patients who don't want invasive surgery, the side effects, we still have to talk about, can be lasting more than just a couple of weeks or even a couple of months.
Hi, Dr. Sarva, Stephanie Rabakis. How are you?
How are you?
I inherited a bunch of your patients.
Uh-oh.
But I was wondering, what are your criteria for dystonia in terms of DBS for patients who don't have like a generalized dystonia or a genetic dystonia? They're more idiopathic or task specific.
The same rules apply for whether it's idiopathic or DIT1 dystonia. So if they're functionally disabled, not responding to standard medications, not responding to botulinum toxin, even cervical dystonia patients, if they're not responding to high doses of toxin, either because they're just getting very temporary improvements or they're just limited by side effects like dysphagia in particular, I'll send for surgical consultation.
And you generally get good results on the dystonia patients?
It takes a while. So the first dystonia lady that I showed you, who developed symptoms in her 20s, I think it took me about 1.5 years of programming to really get her tremor under good control, but she still has a little bit of posturing. I think the posturing takes much longer because of the involvement of all of the pathways later on, but the fast tremulous movements can respond faster, but it can take a year, maybe even longer to really improve with DBS.
Thanks.
Sure.
I think if there are no more questions, we could probably wrap up now, but this is very interesting. Thank you so much. This is very helpful, especially for the residents. Thank you.
My pleasure. Thanks again. Good seeing everyone. Have a good day. Bye.
Thank you all. Have a good weekend.
Bye.